Hello everyone, it's a pleasure to be here. This morning I'll be speaking about the retinal regulation and the neuronal retinal function in diabetic mice. This is my COI. First of all, I would like to speak about minimally invasive evaluation of diabetic retinopathy. It remains unclear which neurodegeneration or vascular damage precedes in diabetic retinopathy. However, it is difficult to investigate the longitudinal relation between neuronal and vascular damage in diabetic patients. Therefore, we observe the longitudinal changes in retinal blood flow regulation and neuronal function over time in type 2 diabetic mice. We use DBDB mice as a type 2 diabetic model. These mice showed hyperglycemia at 4 weeks of age. In our preliminary study, we confirmed that there were no abnormalities in the retinal vasculature and tissue at 20 weeks of age. To measure retinal blood flow, we use special customized laser spectrophlography for mice. Under general anesthesia, we measure the retinal blood flow in the optic nerve head using this technique. We also measure other parameters, as shown here. This is the study protocol. We measure the retinal blood flow and other parameters in DBDB diabetic mice and DBM control mice every 2 weeks from 8 to 20 weeks of age. To evaluate the retinal blood flow regulation, we perform 2 provocations, systemic hyperoxia and flicker stimulation. We previously confirmed using normal mice that systemic hypoxia induced by inhalation of 100% oxygen caused the retinal blood flow to decrease. We also performed the flicker stimulation to increase the retinal blood flow in normal mice. As shown here, 12 Hz flicker stimulation increased the retinal blood flow in normal mice. We also evaluate the neuronal function in the retina using electroretinography as shown here. Briefly, full field ERG were recorded with the PUREC after the ISF standard maximum response. This slide shows the result of the longitudinal changes in systemic and ocular parameters in diabetic DBDB mice and DBM mice. The body weight and casual blood glucose significantly increased in diabetic mice compared with those in control mice. But there were no significant difference in the systemic blood pressure, intraocular pressure, and ocular perfusion pressure between the groups. It is worth noting that there was no significant difference in the baseline retinal blood flow between the groups. These results suggest that the baseline blood flow measurement is insufficient for early detection of vascular dysfunction in diabetes. Therefore, it is important to evaluate the changes in retinal blood flow in response to physiological stimuli. This slide clearly shows that the blood flow response to systemic hyperoxia was blunted in diabetic mice compared with normal mice at 8 weeks of age. You can see the longitudinal changes in the retinal blood flow from 10, 12, 14, 16, 18, and 20 weeks of age in both groups. There were significant differences in the changes in retinal blood flow in response to systemic hyperoxia between the groups from 8 to 20 weeks of age. We also found that the blood flow response to flicker stimulation was blunted in diabetic mice compared with control mice from 8 to 20 weeks of age. There were no significant differences in amplitude and implicit time in the A and B wave between the groups from 8 to 20 weeks of age. In contrast, the implicit time of oscillatory potential OP second wave was delayed in diabetic mice compared with that in the control mice from 14 to 20 weeks. These results suggest that there were impaired neuronal function in the inner retina beginning at 14 weeks of age in diabetic mice. We also performed immunohistochemistry at 20 weeks in control and diabetic mice. In normal mice, GFAP staining can be observed only astrocyte, but GFAP staining increase in the Muller cells in diabetic mice, suggesting that the Muller glial cell function may be impaired in diabetic mice. We confirmed previously that the retinal glial cell play an important role in blood flow regulation in response to systemic hyperoxia and flicker stimulation in cats. Therefore, we believe that the impaired glial cells in the retina may be involved with the retinal blood flow dysregulation in diabetic mice, which we found in the current study. Here is our hypothesis of impaired retinal blood flow in diabetic retinopathy. First, chronic hyperglycemia causes Muller cell dysfunction in the retina, which can be detected non-invasively by physiological propagation as impaired neurovascular coupling. Neuronal dysfunction then occurred. It can be detected by the electrophysiography as delayed implicit time of the oscillatory potential wave. If the impaired retinal function continued, diabetic retinopathy occurred and progressed to the proliferative diabetic retinopathy and diabetic macular edema. If this is the case, we would like to define the stage between no diabetic retinopathy and non-proliferative diabetic retinopathy as subclinical diabetic retinopathy. Subclinical diabetic retinopathy may be the target in which we have to start the treatment to prevent the diabetic retinopathy. In second part, I would like to speak about the minimally invasive treatment of diabetic retinopathy. I have been searching for novel treatment of diabetic retinopathy for 15 years using isolated porcine retinal arterial technique. As shown in this slide, we found that some drugs which are already widely used in internal medicine can dilate retinal arterioles, which means these existing drugs may have a potential to improve retinal blood flow in diabetic patients. Among them, fenofibrate had a good response to dilate the retinal arteriole, so we believe that fenofibrate may be a new drug candidate to improve retinal vascular function in diabetic retinopathy. This is because two randomized clinical trials, such as a FIELD and a COLD, reported inhibitory effect of oral fenofibrate on diabetic retinopathy. In addition, DRCR-NET has just started a new protocol AF to evaluate the effect of systemic administration of fenofibrate for the prevention of diabetic retinopathy worsening. If this study will be completed successfully, fenofibrate will gain great attention. However, it is difficult for our ophthalmologists to use fenofibrate because of rare but severe systemic side effects such as rhabdomyolysis and acute renal failure. To prevent this systemic side effect, we use nano eye drop technique to use fenofibrate as a topical eye drop. This technique increases the corneal permeability, and the drug can be delivered to the retina by the penetration via uveoscleral pathway. We confirmed that the high concentration of fenofibrate migrated into the retina. Peaking the fiber was after the administration of phenonano eye drop in normal mice. We applied the phenonano eye drop twice daily from 6 to 14 weeks in diabetic mice. This slide shows the effect of phenonano eye drop on the response of blood flow and ERG in diabetic mice. As shown in this slide, phenonano eye drop improved the retinal blood flow response to hyperoxia and flicker stimulation and ERG parameters. ERG parameters also improved. These results suggest that phenonano eye drop can improve vascular and neuronal response in diabetic mice. Phenonano eye drop decreased the GFAP expression in diabetic mice, suggesting that phenonano eye drop protect mirror glial cell dysfunction in diabetic retina. We also observed that the phenonano eye drop decreased the VEGF and albumin staining. These findings suggest that phenonano eye drop also improved vascular permeability. Of course, we need a clinical trial to examine the effect of phenonano eye drop on diabetic retinopathy. In conclusion, our results suggest that the deficiencies in flow regulation and the neurovascular coupling in the retina appear to precede neuronal dysfunction in mice with type 2 diabetes. In addition, nano eye drop of fenofibrate improved the retinal blood flow dysregulation and the neuronal retinal dysfunction, and prevents the retinal glial dysfunction and VEGF overexpression in type 2 diabetic mice. I would like to express my sincere gratitude to our colleague and our collaborators. Thank you for your attention.